Hello everyone. Today we'll talk about the diagnosis of leukemia. To make a diagnosis of leukemia, we have to consider the clinical manifestations, the bone marrow, and also the blood examinations. Let's start from the clinical manifestation. The clinical manifestation of leukemia are caused by other failure of normal hematopoiesis and leukemic cells infiltration. The patients can have anemia, bleeding, and secondary infection caused by hematopoiesis failure. Leukemic cells can infiltrate into liver, spleen, bone and joint, oral cavity and skin, ocular region, CNS, testicle, and thymus, etc. This causes hepatosplenomegaly, bone pain, swollen germ, loss of sight, headache, etc. Bleeding is a presenting feature in about 40% of patients. Hemorrhagic signs vary in field and degree, from subtle hemorrhage in skin to CNS bleeding. Widespread bleeding can be observed in patients with disseminated intravascular coagulation. It happens mostly in APL. 62% of patients died from bleeding. 87% among them died from intracranial hemorrhage. There is a various degree of anemia in leukemia patients. It usually gets gradually worse. Half patients with severe anemia at diagnosis. Fever may be seen in half of the patients, usually caused by infection or leukemia itself. The doctors should also pay attention to the fungal infection in case of fever. Hepatosplenomegaly and adenopathy are common in lymphocytic leukemia. Splenomegaly is most common in CML. When the bone joints are involved, patient will feel pain and sternal tenderness. Severe bone pain occurs when bone marrow is necrosis. If ocular site is involved, there will be a granulocytic sarcoma, also called scleroma. It often involves periosteum, most common in the orbital, causes exophthalmos, amblyopia, or blindness. Central nervous system is often attacked after achieving CR, most common in ALL. Spinal cord infiltration results in paraplegia. Nerve root infiltration results in cachexia. To make a diagnosis of leukemia, we have to do lab examination including peripheral blood and bone marrow. For bone marrow, morphology, immunophenotyping, cytogenetics, and molecular biology need to perform. In peripheral blood, WBC count can be either elevated, normal, or reduced. There is usually a progressive anemia and thrombocytopenia. A great deal of blood and all precursors may be present in peripheral blood. Bone marrow of leukemia patients is often hypercellular. Leukemic blood cells are equal or more than 20%. Normal nucleated RBC and macrocytes are reduced. Orals are pathognomonic of acute myeloid leukemia, result from crystallization of myeloperoxidase granules. They are most commonly seen in elderly myeloid precursors in certain subtypes of myeloid leukemia. Presence of orals in mature neutrophils is sporadic. We should pay attention that there is also hypocellular leukemia. Cytochemical stain is helpful in the identification of lineage of leukemia bloods. Pure X is strongly stained in acute granulocytic leukemia. PS is positive in acute lymphocytic leukemia, but usually negative to positive in other leukemia. NS is positive in acute monocytic leukemia and can be inhibited by sodium fluoride. AAP is increased in ALL and reduced or negative in acute granulocytic leukemia, normal or increased in acute monocytic leukemia. Immunophenotyping is very important for determination of cell lineage involved. Each subtype has a special panel of CEDs. For example, M1 usually has CD33, CD13, CD15 expression. M2 almost the same as M1. M3 has CD33, CD15, CD13 positive, and HLA-DR negative, CD34 negative. M4 and M5 are both CD33, CD13, CD14, CD15 positive. M6 has CD71, glycophorin A, RBC spectrum expression. M7 has CD41, CD42, CD61, VWF expression. While in TLL, there are CD2, CD5, CD7 expression. And for BALL, there are CD10, CD19, CD20, CD22 expression. The cytogenetics and molecular biology is closely related to the prognosis for leukemia. For example, in M3, there is a translocation between chromosome 15 and chromosome 17. The mutation involves two genes, the PML gene on chromosome 15 and the RARA gene on chromosome 17. The translocation between chromosome 15 and 17 fused part of PML gene with part of RARA gene. The protein produced from this fused gene is known as PML-RARA. The PML-RARA protein interferes with the normal function of both the PML and also the RARA proteins. As a result, blood cells are stuck at the promyelocyte stage, and they proliferate abnormally. Excess promyelocytes accumulate in the bone marrow, leading to acute promyelocytic leukemia. The mutation translocation of chromosome 8 and 21 is often found in M2 and leads to AFL1 ETO fusion gene. Patients with a invert or deletion of chromosome 16 usually correspond to the subclass of AML M4EO with a specific abnormal eosinophil components and are CBF-beta MIS11 fusion gene. The above mutations are related with good prognosis. Translocation between chromosome 9 and 22 is found in 5 to 20% of ALL patients. That will lead to BCR-ABL fusion gene. This mutation means bad prognosis. Take all the information, including clinical manifestation, blood, and bone marrow examination. We can make a diagnosis of leukemia. Thank you. Next time, we'll talk about the treatment of leukemia.